Hello, this is a presentation by Felix Carrion, your narrator, about the background and relevant clinical discussion in the use of a piece of equipment for blood flow neurofeedback or hemoencephalogram neurofeedback using the PIR3 equipment and headgear as part of the Signet and NeuroAmp platform. This presentation is based on my experience with neurofeedback, including the use of blood flow neurofeedback or HEG neurofeedback. This material is primarily directed at the neurofeedback practitioner that uses the Signet platform and the Othmer method. The Othmer method is still a frequency-based approach, and this presentation is for those that have a background using traditional approaches and trying to move beyond that when that approach does not work as well. I should note that my background is as a licensed psychologist using neurofeedback for the last 28 years for a variety of clinical presentations. As additional background, it's important to note briefly that HEG neurofeedback is associated with Herschel Tuman and Jeff Carman. The main difference is that Tuman's approach used a near-infrared device with one sensor on the headband. Carman's approach uses passive infrared. The idea is to use either one of these methods to track either the color underneath the sensors, infrared cameras, and the temperature. For the present PIR3 approach, the use of this method focuses on the temperature underneath the sensor. It's also important to remember that developmentally, for me as a professional, this includes not only my clinical experience, but my review of the literature and research. The main focus has been on the frontal lobes. Alkanon Goldberg emphasizes in his book about the new frontal lobes that this is an area of the brain. They are the last to fully develop and come online and the first to go, I would paraphrase. I believe that this reflects the developmental stages in brain integration and the need at each stage of development to allocate resources to support that level or stage of development and integration. This is represented in blood flow. And as I stated in this particular slide, this is similar to the idea that you don't go swimming after eating a meal because the body allocates blood flow resources to muscles to support swimming. If not, you may place yourself at danger. A similar thing happens at different levels of development where there's not enough blood flow to support what the brain has to do. This can be due to a variety of reasons, including genetics, hormonal, actual injury to the brain, or exposure to pathogenic environments and adverse conditions. The basic premise for the use of the PIR3 is based on a number of studies that found that many different psychiatric conditions correspond to hypoperfusion or limited blood flow, and that this may be related to those conditions and those symptoms. The logic is that by improving blood flow cortically, you can help the patient regain brain function and a reduction of symptoms. By using the PIR3, we're hoping to address that in a very direct way by supporting the functioning of the frontal lobes. This idea and the need for this approach came home to me while working with children who have been exposed to trauma. Many of these children displayed many forms of developmental delays, including speech, attentional, mood and depression, and for those that were old enough, reading and math problems, among other conditions. They also would display poor emotional regulation, poor social engagement, poor social awareness, and episodes of anxiety or rage. You'll notice that the issues related to speech, attention, reading, and math all relate to the left area of the brain, whereas those related to emotional regulation tend to relate to the right hemisphere. The main issue between these two areas of development and brain function is the need to shift between the two areas of the brain. And this is mostly related to the anterior cingulate gyrus and the striatum. I noticed that outside the foster care population, many conditions and many individuals have similar problems. They're unable to shift and lock in emotionally, and they're unable to access the left hemisphere in a way that allows for support and management of the right hemisphere. When I do use the HEG and PIR3, I want to make it clear that I use the Hoffman method, but I also have developed a modification of the method. This includes the HEG approach. I find that the Hoffman method is extremely good for 85 to 90% of the people that I work with. But there are some cases that do not respond very well. That might be 10 to 15% of the population that doesn't appear to be ready to work with EEG-based neurofeedback. For that population, the clearest indication that they need to switch to include PIR3 or HEG is that they will respond to the EEG-based neurofeedback, but then collapse sometime after the session. They seem to go back to a base rate. This is what allowed me to see that this is a population that has a more elemental factor missing. Other conditions for the use of the HEG neurofeedback are those related to people who have been traumatized. It's easy to assume, and supported by clinical experience, that these critical developmental points in which allocations for the left hemisphere don't occur for individuals exposed to these conditions, and that supporting or feeding the brain, so to speak, through blood flow-based neurofeedback is essential. If you can consider for a moment that each action or behavior of the brain is supported by what happens before it gets to the frontal lobes. The ultimate purpose of having a brain, it seems to me, is to be able to generate an adaptive behavior. And that is primarily dependent on that flow of information and an efficient frontal lobe. The use of the PIR3 is probably the most direct way to address what would have been naturally occurring process and to help the person when it fails to occur successfully. This has also led me to the conclusion that neurofeedback is a developmental intervention, regardless of the person's age. The purpose is to assist the brain in engaging in the allocation of those resources to the frontal lobe. Beyond this discussion, there are videos introducing the use of the headgear, the Signet program for the use of a session, and so on. After that, I will introduce the use of the PIR3 with a particular focus on obsessive-compulsive types of disorders, which actually may be more prevalent than many individuals realize. Hello, welcome to my presentation on the use of the PIR3 equipment for blood flow neurofeedback. This is the headband, and you notice that the FP1 or the left side, FPZ or the mid area, and FP2 are designated. On the inside are the infrared cameras that record blood flow temperature across the frontal lobes. This is a very sturdy piece of equipment that has lasted quite a few years for me. This is the point of contact of the headgear into the NeuroAmp. It's important to secure it well. And this is the cable for the NeuroAmp running into the training computer. I am now placing the headband onto the subject. It's important to secure it well. Place it above the eyebrows and eliminate hair. Here's the display where I have the FP1, the left side, at 70% weight. I'm going to bring down the FPZ to 15% and adjust the FP2 to 15% also. This is the arrangement that I have found to be the most useful for most people. This is the level of reward or success rate. I adjust that to 95%. You can use this again with any other program that you have purchased for your NeuroAmp. This includes the use of videos, movies, and so on. We'll set this up with inner tubes for this presentation. I should mention that for most beginning neurofeedback patients, I will start with inner tubes anyway. It's simpler to track people's responses without the strong cognitive or emotional content of movies. We've turned the system on. It's now recording data. And this is the screen full on, allowing us to track the FP1, which is the turquoise. And as with many of the neurofeedback environments, the person is staying within parameters and receives an award by keeping the screen on and the volume up. It fades away when the person is out of the parameters set for the training. I should mention that this is very different than the EEG type training. Here I am removing the headset carefully. The following presentation will include my comments and notes, including a PowerPoint about the use of the HEG with obsessive compulsive conditions. In this final portion of this presentation, I will present a clinical model, an ad hoc model that I use in treatment. Beginning with my interest with my most severe case of OCD when I was working at a community mental health center. This led me to feel a need to research OCD and any kind of treatment that's been used in the past. This led me to a discovery that in Mass General Hospital in the 1960s, they were still using psychosurgery. And the model used at that time was that they theorized that OCD had to do with the anterior cingulate gyrus. I should note that at this point we would have to include the striatum as part of this complex structure that leads into the frontal lobes. The thinking at that time was that the anterior cingulate gyrus was involved in being able to switch and with cognitive and attentional flexibility. The truism is that whatever it is a person pays attention to is the most important thing to the brain, regardless of the fact that it actually may not be that important to pay attention to. This is especially important when thinking about the interaction with the right hemisphere, and specifically the amygdala, which adds the emotional color or tag to our experiences. If the material that we're dealing with has a strong emotional tag of threat, producing fear or anger and even rage, the locking in of attention to that material becomes what we would call a kind of hijacking of the brain. The person begins to hyperfocus, and the brain desperately seeks resolution, but it cannot shift. Resolution is what the frontal lobes provide for us so that we can move on, take a course of action that hopefully is adaptive and allows for resolution, part of an overall feedback loop. At this point, as part of this disclaimer, I want to give thanks to B-Medic, the EEG Institute, and all those individuals that have been involved in my clinical development and in the use of all forms of neurofeedback. I want to make reference to the significant influence of Dr. Goldberg, a student of Alexander Luria in the former Soviet Union, and in his ongoing research about the importance of the frontal lobes. As part of the training and coursework with him, the importance and the dominance of the striatum, a kind of shorthand for these complex systems that feed into the frontal lobes, allow me to think of these areas of the brain that become dominant when the frontal lobes are underactivated. The interaction again between the striatum, the cingulate gyrus, and the amygdala is what leads to these kinds of obsessive compulsive looping where there is no resolution. This is a common problem across many conditions, not only in actual OCD, Tourette syndrome, and many other situations where the person simply cannot get out of the loop. This is a main source of misery, not only for the person experiencing these problems, but for the world and people around them. In the neurofeedback approaches that I have been trained in and used, certainly in the Opera method, the main approach is to quiet the right hemisphere. In the earlier days, we used the 12 to 15, and over time I began to use frequencies closer to alpha, that is 7 to 8 hertz, and eventually the use of infrared low, which is associated more with helping the brain restore default mode. The question is, how can you quiet the striatum and anterior cingulate gyrus network and support the frontal lobes? What's another strategy that could help support the frontal lobes to take executive control? Again, this is where the use of the PIRX3 has been the most useful. As noted in the videos that I presented prior to this section, I would typically set up the dashboard to favor the frontal left side, FP1. I typically would use a 70, 15, 15 weight with a 90-95% reward rate. What I've noticed is that for most people, it takes about 10 minutes before the brain figures out what we're trying to encourage it to do, which is to allow on the screen the turquoise color to ride over all the other temperature recordings. It should be noted that I've never seen anyone actually reach 98.6, the standard for the average temperature. However, if a person is able to increase the temperature, especially on FP1 or the left side, there is general improvement, even by 1/4 of a degree. final considerations are that it takes 1 to 5 sessions for the most severe cases. During a regular session, let's say a 30-minute session, breaks may be needed. However, if you plan to include EEG-based neurofeedback, including infralow, you can do so after 10 minutes of training with the PIR3. I have noted that it's important for the person to stay well hydrated and to eat a high-protein meal after the use of the PIR3. Final notes are the importance of the findings that certain kinds of infections, including pandas, which is related to streptococcus, can bring on sudden onset OCD, especially in children. I have also noted a similar thing occur with adults even after COVID, perhaps as a kind of long COVID symptom.